Ladies and gentlemen, will you please welcome Dr. Joseph Burrascano.
Technical difficulties. Good morning. It's an honor for me to be here today to speak before you and share my experiences. I had been in clinical practice for over 25 years treating Lyme disease patients, and during that time I've seen over 13,000 cases from beginning to the end. And what I'd like to do today is share some of my experiences and the research and literature that support the kind of work that we do. One of the things I recognize, and I think all of you will recognize if you haven't already, is that every Lyme patient is different. And so what I hope to do with my two series of lectures today and tomorrow is give you the background on how to approach the illness, how to approach the patient, so you can make your own decisions based on what you see clinically. So we'll begin. I have no conflicts of interest financially to declare. I wanted to also begin with a little bit of history, because we all know there's a conflict in the world of Lyme disease. Some believe in one type of treatment, others believe in different types of treatment, and I want to explain how that came to be in America today. So as we all know, the original work with Lyme disease came here from Europe with description of the acrodermatitis rash, erythemochronic migraines, which was later named EM rash by Dr. Bernard Berger, Southampton dermatologist. Incidentally, Southampton is part of New York State where I live, where Dr. Alan McDonald had worked, and where many of our patients came from. I'll share that in a minute. In 1921, the connection to tick bites and these other illnesses was made. And as time went on, the researchers found association with neurological problems, psychiatric problems, arthritic symptoms, and so forth. So this foundation of Lyme disease, as we know it today, is actually very old and began in Europe. In the United States, in the early 1960s, an internist, a retired medical doctor in Montauk, New York, which is again near Southampton, described expanding circular rashes on his sick patients, and these rashes would respond to penicillin. He also described a monoarthritis of the knee. He called it Montauk knee, named after the town. In Wisconsin, the center of the United States, Dr. Scrimenti actually wrote an article on the ECM rash appearing in the United States. He also found that it responded to penicillin treatment. In the mid-1970s, after many, many years of trying, mothers, who as we know are the best activists in the world, came to the American government and said, we need to have someone investigate why all the children in our neighborhood have arthritis, Bell's palsy, and are sick. So finally the CDC sent Dr. Alan Steer to Connecticut, where he described what he called Lyme arthritis. It was 1977. However, his background was not infectious disease, it was rheumatology, arthritic diseases. So his mindset was that Lyme disease was an arthritis. It was called Lyme arthritis. As a rheumatologist, his treatments were anti-inflammatory, aspirins, perhaps steroids. He didn't think it persisted, so maybe a virus is what triggered it off. However, in 1982, Dr. Willy Bergdorfer, who had been well known for his work with relapsing fever Borrelia, came to, again, Eastern Long Island, in the same area that I've been talking about. He found the spirochete that they eventually named after him, Borrelia burgdorferi. And I'll show you a little map of this. The epicenter of Lyme disease in America. This here is Southampton, where the hospital that Dr. McDonald and I worked at, also where Dr. Berger, the dermatologist, was. Montauk with Montauk knee and early EM rashes. Shelter Island, where the ticks were collected by Dr. Willy Bergdorfer, where they found the Borrelia burgdorferi, and across the water is Lyme, Connecticut. This is also nature preserves with many bird flyways, and you can imagine how the ticks were carried from one place to the other. Now, part of the problem in approaching borreliosis is that it's not one illness. There are many, many different Borrelia. As I made this slide, I already realized that there's several different species that are not even on here. And within each species, there are many different strains. And in fact, it's not so much that there are different strains, but the Borrelia will change over time, even within their own host. For example, back in the 1970s, a famous Borreliologist, Dr. Folsenfeld, had mentioned how these Borrelia will adapt, and over time, as they adapt to new environments, new genospecies and strains will emerge. Dr. Packner, a neurologist, in 1989, infected a mouse with a specific strain of Borrelia. After the mouse was infected for a number of months, he sacrificed the mouse and analyzed the Borrelia. He found the strain of Borrelia that he originally injected could be isolated from the tissues, but the strain in the brain and the nervous system was a different strain. The Borrelia adapted to a different environment. So if a test, for example, were developed based on the body strain, it would not pick up the neurologic strain that developed in the same mouse from the same one Borrelia. Now, as Borrelia transmit from the tick to the host, another change occurs in a similar fashion. On all these types of changes, the fact that Borrelia can change so easily and adapt to the environment adds to the difficulties in diagnosis and treatment. Now, Borrelia burgdorferi contains the most complex genome of any known bacterial species. And as you can imagine, it must have the adaptability to live in mammals, reptiles, birds, and ticks, of course. The genetics include chromosomal DNA and plasmid DNA. Plasmids can be exchanged from one Borrelia to another, and cross-species recombination has been documented, for example, from burgdorferi to Borrelia americana. Also, another phenomenon is called epitope switching. The Borrelia undergo regular program changes in gene expression. These gene changes result in changes in the surface antigens, giving what it looks like a different serological strain. This interferes with the host's ability to mount and maintain a good immune defense, because as the immune system adapts to and recognizes the Borrelia strain, it changes. And now there's a whole new infection coming along to the body's immune system. That's why often we see a late appearing IgM response in the immune system, which often is thought to be of an early infection. Well, this is a new expression of an old infection, and the body thinks of it as a new infection, get an IgM response. Again, making serologic tests less accurate. Now, the ticks, they have a 2-year life cycle, at least in North America. They will survive our winters. It's been said it has to be less than minus 10 degrees Celsius for them to die. But they can be found active all year long when temperatures above freezing. I'll show you another picture. As if you didn't know this, but Borrelia basically is worldwide. It's found in pretty much every continent except Antarctica, but it's probably there too, but we just haven't looked. Recent article, 29% of ticks found at and above the Arctic Circle in Norway contain Borrelia. This was just recently published. So it's here now, and all this you do know. Now, some clinical important pearls of wisdom. It had been said that you need to have a tick attached for 24 to 36 hours to transmit the infection. Those studies were based on animal studies with rabbits. Rabbits don't get Lyme disease the way humans do, so that's one bit of misinformation. Secondly, Dr. Bergdorf told me this years ago, and it's printed here, 5 to 10% of ticks contain a systemic infection, meaning the Borrelia are in their saliva. As the tick bites the person, saliva is first injected to anesthetize the skin, inhibit the immune system, and so forth, and at that time the Borrelia can be injected. And indeed, the article was published in 2011 showing that rapid transmission of Borrelia can occur. In fact, in my own clinical experience, I've had many, many patients with Borrelia attachment times of 5 hours or less who got real Lyme Borreliosis documented by rash, serology, and symptoms. So we talk about the diagnosis of Lyme being clinical. We say it's clinical. Why is that? Positive lab testing is not a requirement. It's supportive, but you can have Lyme with a negative Lyme serologic test. Often it becomes a diagnosis of exclusion. You have to make sure the person doesn't have some other similar illness to mimic Lyme disease. Here's some statistics. In the state of Texas, the United States, only 17% of patients recalled a tick bite. In parts of New York State, as well as Texas, only 36%, about 1/3, recalled having a rash. So now it had been said in early literature that everyone with Lyme gets a rash. That was based on studies where people admitted to the clinic if they had a rash. So then they wrote a paper, all people with Lyme have a rash. No, all people in their clinic had a rash because that was the requirement. If you look at people with Lyme disease and you do studies, the range is 36%, maybe 50% have a rash. It's also possible someone can have a rash and they don't see it, it's on their back or in their scalp. So not having a rash does not exclude Lyme disease. Now, serologic testing, I'll show you some slides on this, is not very accurate, and commercial testing will miss around half of the cases. Another thing we found clinically is that patients who are more sick, who've had Lyme for a longer period of time, are more likely to show a negative Lyme test serologically, one of the phenomena of this illness. So how do we make a clinical diagnosis? First of all, we need to have a microphone that works. I will try it once. Ah, I'm back. It's the CDC.
That's funny.
So first we need to have a history consistent with the illness. What is the history of the patient that clues into Lyme disease? Well, you have to recognize the signs and symptoms, but more importantly, Borrelia have a specific pattern of what they do to patients. I'll show you that in a moment. Now, we need to do, of course, testing for specific infections, Lyme and the co-infections as well, but you can have Lyme and not show on one type of test. So often what we do is a panel of tests, different types of tests. We want to do some indirect tests to give an idea of the nature of the infection, what it's done to the patient. You need a logical and detailed type of test to rule out other similar illnesses. Does the patient have cancer, or hepatitis, other forms of illness that might mimic Lyme? And therefore it might be a diagnosis of exclusion. So the history. A well patient who became ill after potential exposure. The occupation, exposure and travel, all these are very important. Do family members have Lyme? Do their pets have Lyme disease? Domestic and wild animals, people who work in the United States around horses, always get Lyme disease. It's very, very common. And again, because ticks can be active all year long, you cannot say, well, you didn't have Lyme because it was in the wintertime. Next thing you notice that the symptoms evolve over time. The patients begin with non-specific, like a virus, they feel tired, aches, so forth. Over time, these will persist, but new ones will appear. Then they become more focused on organ systems. It can become musculoskeletal, peripheral nervous system, central nervous system, heart, skin. Layer by layer, these different areas get involved until it progresses to a whole body multi-system illness. Then what you see are the patterns. As I mentioned earlier, Borrelia have complex genomes and they undergo regular genetic shifts. In fact, that's why they call Borrelia relapsing fever organisms, because it's a pattern of illness, wellness, illness, wellness. Now, in Borrelia burgdorferi, the change in antigen presentation occurs about every 4 weeks. So patients will notice that their symptoms wax and wane every month. They have good weeks and bad weeks, good days and bad days. And if they kept a calendar, which I recommend all the patients do, they will see a 4-week cycle. When the Borrelia undergo their genetic shifts and they start to make new antigen expressions, your body reacts differently. So that's why one cycle you might have headaches. Then they seem to disappear. Then you get pain in the joint, and that gets better. Then you get neurologic, and that gets better. Then the knee, then it gets better. Then it goes back to the headaches. So the patient has this very clinical picture, and the doctors start to think, this patient's crazy. How can they have so many different things? What's the signs of Borrelia? A 4-week cycle, change in symptoms over time. Now, erythema migrans, actually the most common presentation of Lyme tick bite is a small raised rash that does not expand. So the erythema migrans rash is actually not common. And when it does occur, as I said, it could be hidden in parts of the body you did not see. And the appearance may not be the classic bullseye that you've seen published because it does follow skin planes. They're very rarely circular, but they can be raised, warm, and painless. Occasionally they itch, but usually not. And even without treatment, they will disappear. Classical bullseye rash, as I said, this classic appearance is actually quite rare. Here's some more pictures. These are not bullseyes, the rashes are more uniform. Look at this one. It starts more dense and then gets faded as it goes toward the extremities. Now here's some which are not circular. They follow the skin planes. The one on the side follows the torso, and the chest is an irregular pattern. The one on the chest often would be mistaken for a ringworm, a tinea infection. Now, some people have atypical looking rashes. The first one on the left is very erythematous. You would think was more of a cellulitis or a hypersensitivity reaction. Patients of color may have a bluish-black rash, and others may have a rash that really looks like a burn. And here's some other atypical ones. When you see a rash that has a vesicular appearance, in my experience, that often indicates a co-infection with Bartonella. The central rash is highly inflamed, the patient's immune reaction to it is very strong, or they have a more virulent strain of Borrelia. And the last one you can see by the axilla looks almost like a fungal infection. ACA, the echodermatitis chronic atropicans, does appear late, often associated with Abscelii, but Greenia has been reported to occur with this as well. And the inflamed skin slowly becomes atrophic, and underlying is a neuropathy in the affected extremity. And I've seen this in America, which is not supposed to occur, but I have seen it. On the physical exam, it used to be said that most patients with Lyme have a normal physical exam. Actually, it's not true. If you look very carefully, you really must, you will find things. For example, how do they look? How do they speak? How do they think? Many times the Lyme patients look fine, but they can't finish a sentence. Look for rashes. See what the temperature of their skin is. For example, you might find that their skin is warm, yet their feet are blue and cold, despite good pulses. It's a sign of an autonomic neuropathy. Look for redness of the whites of the eyes, congenital injection. Look for the red streaks on the tonsils in the throat. Look for thrush. Very often Lyme patients, because Borrelia is immune suppressive, which I'll discuss later on, will suppress the immune system and allow thrush or yeast infections to develop, even in patients who've never had antibiotics. So you should look for that. Because Lyme disease very often involves, almost always involves, the nervous system, including the autonomic nervous system, you must check them for blood pressure changes with posture. Do they have orthostatic changes with blood pressure? Often patients with Lyme will present with a low temperature in the morning and an above normal temperature in the early afternoon. And in the early afternoons when patients with Lyme feel this exhaustion and you need to lie down with a flushed face. Incidentally, when we do our Borrelia culture studies, that's the best time of day to draw the blood. It seems to be when the Borrelia is most active. You must do a very thorough neurological exam to look at all the cranial nerves, including checking the gag reflex, corneal reflexes, extraocular muscles. Learn to read the reflexes of the patient. They can be absent or decreased from the neuropathy. They can have delayed relaxation from thyroid involvement. They can be brisk reflexes because of magnesium deficiency. They can be closed because of motor neuron disease. So look for that. In every single exam, at every visit, every joint that's successful should be examined, because you will find thickening and tenderness and so forth of all the joints. But you have to look very carefully. And you check every little joint with 2 hands, and you check them for thickening, temperature, and so forth. And if you do it with every patient, at every visit, with every available joint, over time you'll learn how to do this very well. And you can actually see a lot of changes that otherwise people would not have noticed. Look for nodules along the extensor tendons. Very, very common in Lyme, and especially when Bartonella co-infection is present. Look for tenderness. The most common area of infection is in the ligaments and tendons, not in the joint itself. Many patients with Lyme have a stiff neck, and they do what I call the Lyme shrug. They're sitting cracking their neck all day long. That's not a hard sign of Lyme disease, but one of the patterns to look for. Because you want to make sure they don't have some other illness, look for enlargement of the spleen and liver, check the glands, listen to the heart and lungs. Very often Lyme patients get inflammation of the ribs where the costochondral junctions meet, and very often they're in the emergency room thinking they have a heart disease or heart attack, and it's just from infection of the ribs. Laboratory testing, we'll have a whole lecture from Dr. Shah shortly, but I do want to go over some very basic points. Many difficulties with laboratory testing. As I mentioned, there are many, many different types of Borrelia, and we often have our blood tests based on 1 or 2 strains that may not apply to the others. The Borrelia will change over time, so what you've developed as a blood test for a Borrelia may not apply to what's now happening weeks to months later in a patient. I'll give you an example of the genetic diversity. Outer surface protein C reflects just 1 gene locus, yet that 1 locus has 22 variants in rhabdophori. And finally, the wild-type Borrelia specimens that we culture from our patients, they're quite different from the laboratory strains. Yet most of these commercial tests are based on 1, maybe 2 laboratory strains. For example, in America, most of our tests are based on strain B31. This is the strain that was collected from ticks in Shelter Island. This strain came from a tick. It did not come from a human being. It was never tasted the blood of a human. Yet all of our tests, all the research, all the controversy is based on testing from a tick strain that's so different from what's in real people. Even if it was a human strain, it's 1 strain at 1 point in time, and it doesn't reflect how the Borrelia do change. Now, as a result, serologies are very insensitive. One published study that the range of sensitivity averages about 50%. I'll show you another slide on that. Many have heard of the C6 assay as being more accurate. It's as accurate as the standard ELISA. Now here's some trickery. If you read the literature that supports the C6, they say it's 100% sensitive. It's 100% as sensitive as the ELISA, but it's not 100% sensitive in picking up Lyme disease. So if you read the articles carefully, you'll see that this claim of 100% is that it's 100% comparable to the ELISA, not 100% accurate for Lyme disease. The Western blot, very poor sensitivity unless it's done by a specialty lab. And in the presence of certain viruses, you can get false positive serologies. The other paradox, as I mentioned, the more ill patient is less likely to have a positive serology blood test because of immune suppression, and immune complex formation, and so forth. And one big limitation of serology, of course, is it shows prior exposure, not if you're currently infected. This is from the article showing how insensitive the ELISA is. The author claims 49% on average, and he says it's like tossing a coin, 50-50. One of the very important points I like to make when I give presentations and train my physicians is that Lyme is a disease of the central nervous system. It very rapidly disseminates there within hours to days of the tick attachment. So in my mind, all cases of Lyme involve the central nervous system. Hopefully you have blood in your nervous system, so if there's blood in your brain, there's ticks in the brain. Now, unfortunately, when you do serologic testing of spinal fluid, it's very, very insensitive. New York State had a Lyme clinic, a very famous Lyme clinic, headed by Dr. Pat Coyle, a neurologist, and she has presented that only 9% of her Lyme patients, 9% had a positive spinal fluid serology. So 91% of the time was a false reading. So do not rely on the spinal fluid serology to say that you must have central nervous system Lyme. If you have Lyme, it is central nervous system. And this is important because all treatment of Lyme, including in the early stages, should be adequate to get to the central nervous system. Okay, let's talk a little bit about the Western blots. In the United States, we talk about the bands 23 through 5, 31, 34, 39, 83, 93. European strains also have bands 18 and 100, which, in my experience, also show more tendency toward neurological symptoms. So you want to have at least one or preferably two of these specific bands for Borrelia. However, be aware that you can have a late IgM that's positive, and that does not necessarily mean a false positive, though it can. When the bands 31 and 34 are present, these are the bands that are most likely to show cross-reactivity with the nervous system and the joints. So these are the people who have an autoimmune process in addition to the infectious process. Now, in the United States, we have the CDC criteria. These were developed for surveillance, not for diagnosis. They're also altered to accommodate a vaccine that was produced many years ago. And because of that, these criteria are not good for clinical diagnosis. We don't recommend it at all. Now, one of the problems with the Western blot, Dr. Shaw will talk about this, I'm sure, is how do you interpret what it looks like? On the Western blot, we have what are called bands, these little dark lines. So now, to call it positive, you would say these bands are positive. Here, there's no band, that would be negative. What about the little bands here? What about little tiny faint ones? I should not favor one side, the other. So we have very fine bands. So do you call that? Lost the microphone. Hip. So how do you know whether these are positive or not? Is this a phenomenon of position? It's not a computer virus, it's a computer sparky. So part of the problem with Western blot is how do you call a band positive? If you took your patient's blood to 3 different laboratories for Western blot, you might get 3 different responses because there's no standardized way of recommending or recognizing which band would be called positive. And subtle changes in the testing system of chemistry or temperature can change how the banding pattern looks. So yes, the Western blot is much better, in my mind, than a simple ELISA, and certainly better than a C6, but it's not the gold standard. One of the things that I like about the American lab called Diagnostic is that, well, they not only report all the bands that they see, but give you a relative reading. It's not just positive or negative. They say 1 plus, 2 plus, 3 plus, or maybe plus or minus. They let you, the clinician, interpret whether you're going to believe the test or not. DNA testing with PCR does have problems. In the blood, sensitivity is low, at least 30%, maybe 20%, because of peripheral inhibitors and other problems with technical reasons for the blood. When PCRs are done, there are primers that help to get the reaction going. If the primers are very, very specific, you might miss some strains. If they're very broad, you might pick up non-infectious strains. In the United States, they don't accept PCRs for insurance or for CDC. They claim they're contaminated, despite the fact that they accept PCRs for every other illness. And they even use it in cases of murder, where they say someone murdered somebody or not. You can use a PCR, but for Lyme disease, you can't. In the United States, we've had very poor luck with T-cell stimulation assays. And in Europe, they are used much more widely than in America. The American experience has been that they're not that sensitive or specific, and we don't have any widespread clinical studies on how accurate they are. Dr. Schwartzbach will be speaking later, I believe, about this, and hopefully he can give you more information than I can. It's just the United States experience has not been very positive with these tests, mainly because we don't have good tests. It's been known that Borrelia will shed antigens and actually hold spirochetes into the urine. The picture you see here comes from the National Institute of Health in the United States of an intact spirochete seen on electron microscopy from a patient's urine. So you can definitely find spirochetes and antigens of spirochetes in the urine, but the difficulty with urine antigen testing is that we don't have any large studies that are accepted. Also, we don't have good information on whether they pick up all the different species and strains. Again, the United States government and the insurance companies don't like to use this for diagnosis, but as clinicians we do. We now have in the United States direct culture Borrelia, which is a very big advantage because the beauty of a culture, as you know, is that positive culture means the patient was infected at the time the culture is drawn. So not only can it be used for diagnosis, but if someone's been through treatment and treatment has finished and they're still not well, do they have damage? Do they have autoimmunity? Or do they still have infection? With the culture, you can tell. That's why it's very, very good. The CDC in America will accept the culture, as will insurance companies. And in a trial that has been published of patients who are CDC positive by serology, the sensitivity is as high as 94%, which is much higher than the serologies that we have. And in over 3 years of testing, the lab has not found any false positives, despite the criticisms that it received from competitors. In fact, every single time a culture is run, a positive negative is run with every single one, and in over 3 years they've never had a positive. But let me show you an interesting picture. This is why I say that clinical Borrelia is so different from laboratory Borrelia. We'll start on this side. See if my microphone disappears. See? There's a dead spot somewhere here. All right. So, I pressed the wrong button. Go back. So, we have... I have to find the spot. We have Borrelia. Is this better? No. We have Borrelia culture for blood. I will ignore it, maybe it'll go away. And here we have the laboratory strains of Borrelia. You see, so we can tell just by looking in the microscope, a laboratory strain, which again is adapted to live in the laboratory. You can buy this in vials from companies in America. It came from a tick, not from a human. So even under the simple microscope, you can see the difference. However, simple microscopic examination is not always the best. Here, what looks like a spirochete and stains with polyclonal antibody actually was a collagen fragment. This is a collagen stain that was used to show that this, in fact, was not a Borrelia. So simply finding Borrelia in the microscope doesn't always mean you have an infection. You need to use specific stains and counter stains to be really, really sure. But you can see how different these are from the laboratory strain. So again, if there's a contamination of a culture, skilled technologists can see this right away. That's a laboratory strain, not a human strain. Disadvantages of the culture is that it's expensive. They need large volumes of blood. They need usually 30 to 40 cc's of blood. And although about half of them will grow within the first week, some take as long as 4 or even 8 weeks to grow. Some even take 16 weeks to grow. And you know, this is not something that I can tell you officially from the laboratory, but my own experience using the culture, the patients who are very sick have the culture show positive right away. The patients who've been through treatment or who haven't been as badly sick, those are the ones who take a longer time to grow. Either they have a small load of spirochetes or less pathogenic ones. But the more sick patients will show up right away. Another disadvantage is that if the patient's been exposed to antibiotics recently, the test is not accurate. They have to have been off antibiotics for a number of weeks. So I've talked to you about a lot of different things. Sometimes it's confusing. Almost all the time it's confusing. So what we've done is we've put together a point system. And this is published in my Lyme guidelines, which are available over the internet. but it's a weighted average of different points, how many points you get for having different things. And when you put it together and add it up, you find that you can get a pretty good idea of whether the borreliosis is present just by using the clinical scheme. Let me go back one more time. So you can see, for example, DNA recovery gives you 4 points, history gives you 2 points, and you add them up. This point system was validated in 2 separate studies of over 150 patients and 50 controls. So I find it to be very useful. It's also good for documenting on your chart. One other thing we found useful recently is complement split product C4A. It's not specific for Lyme, but is a marker of how active the disease is. If the person does not have, for example, lupus or rheumatoid and the C4A is elevated, you can use that to help follow the Lyme course. And as treatment is working, the C4A level will eventually go down toward normal. So the recommendations that we have for laboratory testing is that the initial draw should include not a C6, not an ELISA, but I would just go with a Western blot if you can, because you get much more information. A C4A is helpful also. If the person is seronegative, what you can do is you can do a Borrelia culture. PCR immunogen is also helpful, but the culture is much more accurate. You can follow the progress clinically with the C4A, because if it is elevated, it will drop successfully with treatment, and over time, through treatment, get lower and lower, toward the end, we'll be back to normal. If someone has any persistent or recurrent symptoms post-treatment, again, the culture is very, very important because you want to see whether these are still active Borrelia or whether this is some leftover other problem. Of course, I would replete the Western blot and C4A at least 4 weeks after treatment ended to see a new starting point. Many patients with Lyme, with Borrelia, have a positive anti-nuclear antibody test. And it makes sense because Borrelia, they don't multiply and grow quickly like other bacteria. They often go into a dormant state where they don't multiply, which makes treatment very difficult. I'll speak about this tomorrow. Because antibiotics, as you know, will kill Borrelia and bacteria in general only during their growth phase. So the Borrelia are now in a dormant phase and they're not growing. The antibiotics cannot kill them. But they still secrete biological products that inflame and activate the immune system. And one of the things that they do is they release membrane-bound packets of DNA, their own DNA. Now, it's been found recently that this is how Borrelia communicate with each other, both in biofilms as well as in serologic systems. And this is genetic exchange, this is to coordinate their 4-week cycles and so forth. But it's also nuclear material being secreted by the Borrelia. And we have found in many of our patients that you get a positive anti-nuclear antibody when the infection is active. So it's very easy for a rheumatologist to say, no Lyme disease, you have autoimmune disease. Well, we find with antibiotic treatment, as the Lyme gets better, the anti-nuclear antibody goes away. If the Lyme recurs, the anti-nuclear antibody can become positive again. So it makes clinical sense to see that. Just don't get sidetracked to think that the person does not have Lyme disease. So the final thing, though, is that, yes, we can go with wonderful laboratory tests, but the clinical features are the most important thing. All my patients are asked to keep a daily diary of their symptoms for 2 reasons. One, to see what the symptoms are and how they change over time. The other is to see this 4-week cycle. What I recommend is you have a calendar where each page is 1 month. And you just check off good and bad days. And some patients make colors. Red is a bad day, blue is a good day. And you can see the pattern. And if you see this classic 4-week cycle, that's a sign that the Lyme itself is still active. So, as much as we do the laboratory testing, because we like to have that to support our clinical diagnosis, it's still a clinical diagnosis. I'm going to end this section now so we can have questions, but before I do, I want to announce today and also tomorrow that ILADS, International Lyme Associated Diseases Society, runs a training program for clinicians. Every year they have an annual meeting. This year will be held in October in Washington, D.C. in the United States. And the first day of that is a 1-day training session with Dr. Horowitz and I and others. We'll teach physicians, clinicians in general, all about Lyme disease from the beginning to end. We give a test at the end. If you pass your test, then you'll be eligible to be trained by one of our physicians. ILADS will pay you to spend a week with a physician in their office, following them around once you've been through the training session. If you can't get to the United States for this, you can buy the DVDs from ILADS and take the test. And if you pass the test, then you're eligible. And Dr. Carsten Nicholas, who's here today in Germany, will support training of an ILADS doctor too. So ILADS now has funding to do this. So As much as you hear today from me, from Dr. Horowitz and others, you might get confused and might say, oh, it's too much. No. Insecurity is treated with knowledge. So if you feel that you don't know well enough, ILADS is there for you to help you learn with evidence-based, literature-supported data on how this whole thing works. And so please don't be afraid, and please take up the offer of ILADS to be trained. So let me finish now. I am ahead of schedule unusually. So if there are questions, please. Come to the microphone. How do we do the questions?
Hi. Yeah, we have 10 to 10 minutes for questions. Who's bringing the microphone to this gentleman?
I can manage that.
Okay, beautiful voice.
Okay. My name is Joe Ekman. I'm a medical doctor. Thank you for a very exciting lecture.
Thank you.
I'm curious about, is there a link between the chronic inflammation with Lyme disease and non-Hodgkin's lymphoma? Have you have an idea about that?
In my many years of treating Lyme patients, many years, many patients, I've seen a reverse association. I don't think, in my experience, that borreliosis will induce a lymphoma. However, I've seen patients who have lymphoma, whose immune system was suppressed, and the borreliosis got much worse. I've also seen patients who were thought to have lymphoma and turned out to be a combination of Borrelia and Bartonella. And with appropriate antibiotic therapy, the lymph nodes went away, histology normalized, and the patients did not need chemotherapy. Now, again, these are small numbers of cases, but very, very well documented cases. So again, I don't believe, in my experience, that borreliosis will induce a lymphoma, but on the other hand, lymphomas and any immune suppressive illness will allow Borrelia and co-infections to get worse.
Well,
Can I offer the European? The European experience is different from the U.S. experience. And in the U.S., there is no body of lymphoma associated with borreliosis. In Europe, it's completely different, and there are cutaneous lymphomas, which are usually low grade, that are B-cell lymphomas. There are high-grade lymphomas. And the Italians have shown that there are T-cell lymphomas, like mycosis fungoides, that are associated with Borrelia of the European type. So the European experience, just like we don't have active dermatitis in the U.S., we don't have lymphomas in the U.S., and we don't have dilated cardiomyopathy in the U.S. yet, but that's because it hasn't been looked for. But the European experience is different, and yes, in Europe, assuredly so, and lymphomas have sprung from the center of ACA lesions. So a picture of an ACA lesion that's been there for 30 years, and the lymphoma pops out of the center of it. And you can also get squamous cell cancers popping out of the center of an ACA lesion. So the European is different from the U.S., and Joe's correct about the U.S., but Europe is ahead in many regards in Borrelia medicine, and particularly with these difficult topics.
Yes.
Someone wants the microphone?
I got a microphone. My name is Anja Eikeland. I'm a neurologist, and I've been working with Borrelia research for many years. And I'm also now the leader of the Norwegian National Advisory Unit for Tick-borne diseases, a very long name. Thank you for a very interesting presentation. I just have one critical question for you. I couldn't help notice that the literature you use as a reference is very old. And I've been reading this literature from Donta from 2007 and from Russo from 1999. And Sticker is somewhat newer. But they do not difference between late and early Lyme disease. And I also agree with you that maybe just 9% of the patients are positive in the CNS, if they in the spinal fluid, but that's not because they don't. They have not neuroborreliosis. They have other kinds of disease like erythema migrans or arthritis. And you also have to remember that the species in Norway is very different from those in the US. So it sounds like the tests are very, very bad, but I think you are, I do not agree with you that they are so bad. Thank you.
Well, you know, it also is a matter of definition, because if you read the literature on neuroborreliosis and the serologic diagnosis based on spinal fluid serologies, they're defining neuroborreliosis as a condition with a positive spinal fluid serology. So if you understand that, you really shouldn't use the term neuroborreliosis. You could maybe call it spinal fluid positive borreliosis. But all borreliosis, which is systemic, you know, there are some borrelia that just say localized in the skin. But if you have a systemic borreliosis, it's been shown over and over again in animal as well as human studies in our experience with the culture that it is bloodborne, not only early in the disease, but intermittently thereafter. And it definitely goes to the central nervous system. Borrelia will very readily penetrate through endothelial layers, and they will reside in neurons and glia and interstitial spaces in the nervous system. So pretty much all disseminated Lyme does involve direct invasion of the central nervous system. Now, just because you don't have a serologic response in the spinal fluid doesn't mean that it's not in the central nervous system. One of the problems is if you examine spinal fluid for Borrelia, it's a hostile environment. And as you'll see from other lectures today and mine tomorrow, in such environments, Borrelia will coil up into a cyst, which does not contain surface antigens, which will not induce an immune response, including a serological one in the spinal fluid. So again, you can't say that a negative serology in the spinal fluid means there's no Borrelia in the spinal fluid or in the nervous system. It just means you don't have that form of borreliosis called neuroborreliosis, which is a laboratory diagnosis, not a clinical one. And we've seen many, many, many cases of patients with absolute neurological signs and symptoms who've had completely normal spinal fluids. Many of them also have had elevated white cells and protein, but normal or non-reactive spinal fluid serologies, who went on to respond very well to treatment. So again, to say positive spinal serology must mean neuroborreliosis. It's a matter of definition, but it doesn't mean that you don't have it in the central nervous system.
Kathy? For more, we can one or two other questions.
Kanske tränger den bak. Hallå? Då får vi den. Tack.
Okay. My name is Krzysztof Marigua. I'm from Poland. I'm a medical doctor. I would like to hear your comment, something more about anti-nuclear antibodies. Because you said it's correlating with activity, but does it mean it's correlating with some specific symptoms, like when my patient have anti-nuclear antibodies? And the second question about anti-nuclear antibodies. Do you try to find if this, when a patient has anti-nuclear antibodies, if there is any aggressive disease like lupus or rheumatoid arthritis, or you just wait for what will happen after antibiotic therapy? Do you look for the other antibodies like double-strand DNA antibody and the others?
That's exactly correct. In borreliosis, if the Borrelia is the cause of the anti-nuclear antibody elevation, you can do more specific testing such as double-stranded, the DNA, that generally does not show positive. So it's one way to help differentiate the condition of lupus with double-stranded DNA from that of Lyme disease, which usually does not. Of course, with treatment, you can see the difference. A whole question, though, with any autoimmune disease is it a phenomenon of the immune system, or is there some infection that is driving it? And as you know, medicine advances, we're finding these theories that many, many autoimmune diseases are driven by bacteria. Maybe Borrelia is just one of the co-infections, for sure, could be. So clinically, we do, as I said, borreliosis is often a diagnosis of exclusion, so you look for the rheumatologic conditions and treat them. But many patients who've been misdiagnosed as having rheumatologic conditions who in fact have borreliosis with positive markers such as anti-nuclear antibodies, even rheumatoid factor, will have these markers go away and illness go away with appropriate antibiotic therapy. Dr. McDonald, do you have a question?
I think he put it perfectly.
Dr. McDonald is my mentor. You'll see tomorrow I have a whole section of my speech devoted to his findings because it's his research using Borrelia cultures that actually began this whole ILADS point of view, showing that yes, you can have Borrelia with a negative serology, and yes, you can have Borrelia despite being treated with antibiotics. So stick around for tomorrow. It's getting very exciting. I think we're done.
Anybody else?
One more.
Thank you very much. My name is Ross Anderson. I founded Cure the CDC. It's a little fun page we have for harassing the CDC, trying to get them to change what they're doing. My question is, how big of a role is Epstein-Barr virus and some of these other viruses playing in our symptoms as patients?
The question is Epstein-Barr virus and Lyme and Borrelia. You know, it's a very difficult issue to sort out clinically because, as I'll speak more about tomorrow, Borrelia will impact the immune system in a negative way. It's been shown to affect, in a negative way, B cells, T cells, and the killer cells, which are all three arms of our immune system. They will both inhibit their function and actually kill some of these cells. So if you have an active infection, at least present for many months, if not more than a year, when this immune system problem occurs, if you've had a prior exposure to Epstein-Barr and other DNA-type viruses, they can reactivate and become part of the mix. If you have a newly ill patient who's got a positive Epstein-Barr titer and maybe a positive Borrelia test and maybe a borderline serology, it becomes very difficult to determine whether it's a primary mononucleosis or a bacterial infection. It's also been known that DNA viruses such as Epstein-Barr can give a false positive reading on IgM. And one of the labs that we use in America, IGenics, will do what's called an epitope test to help you differentiate that on a Western blot. So it is a difficult clinical decision. I've shown case histories of patients who had chronic Lyme disease, borreliosis, and who had positive viral titers, who did not respond to antiviral therapy at all, but did respond to the antibiotics. And as their immune system reconstituted and healed, the viral titers and viral symptoms went down. A study was done at Stanford University in California, showing that patients who have very, very high antiviral titers, such as 640 or above, they may separately respond to antiviral therapy, and that's one of the things you do have to look for. But again, the problem with the viruses is that most of us have been exposed. And the question is, are the viruses the primary insult or are they the secondary result of having a suppressed immune system? And many, many years I chased these positive titers with antiviral drugs with no benefit. But once the borreliosis was cleared by both antibiotics and other supportive treatments to get the immune system to heal, then the viral titers went down, the viral symptoms disappeared, and they did not need any antiviral therapy. So the cases that do need separate antiviral therapy are very small in number. Dr. Horowitz will show you cases about that later on. I think we're done. Well, thank you. This has been wonderful.
Thank you.